Dr. Swadha, please.
Yes. Good evening, sir.
Good evening.
Today I am presenting case history of 17-year-old female child, Hanshika Turali. She is Hindu by religion and residing at Chandrapuri, Durg. Informant is mother and history seems to be reliable. She admitted on 3rd of April with chief complaint of not gaining height since past 5 years and bleeding per vagina since 12 days. Patient is apparently normal and had appropriate growth till 12 years of age. However, past year, there's no significant increase in height compared to peers and younger siblings. And earlier, she used to stand at the back during prayers, and now she used to stand at first position in the rows, as per mother. Additionally, patient is having history of bleeding per vagina since 12 days. No history suggestive of excessive blood flow. Patient attend menarche at the age of 13 years, and since last 1 year, cycle interval decreases to 20 to 22 days. Earlier, it was at interval of 28 to 30 days. Blood flow remains for 5 days, and there is no history of excessive blood loss. History of blood transfusion, 1 unit of PRBC after admission. Since last 1 year, history associated with increased irritability, easy fatigability, as she refuses to do domestic works, which used to do earlier with interest, decreased sweating, cold intolerance, and dry skin. There's no history of recurrent fever, cough, loose stool, weight loss, which is suggestive of chronic infections like asthma, tuberculosis, malabsorption, or any recurrent infection. No history of hypoglycemia, polyuria, polydipsia, polyphagia, suggestive of diabetes mellitus. There's no history of easy bruising, gum bleeding, epistaxis, ecchymosis, which is suggestive of bleeding disorder. There's no history of jaundice, abdominal distension, or hepatitis, which is suggestive of chronic liver disease. There's no history of cyanosis, dyspnea, suggestive of heart disease or congenital heart disease. There's no history of edema, hypertension, altered urination, suggestive of renal disease. There's no history of recurrent blood transfusion, which is suggestive of thalassemia or sickle cell anemia or chronic anemia. No history of headache, vomiting, or visual problems suggestive of intracranial tumors. There's no history of regular drug intake like steroids and antiepileptics like valproate, phenytoin, and phenobarb or amiodarone. There is no history of any skin changes. Past history, there's no history of trauma and surgery, no history of recurrent hospital admissions, there's no history of tubercular contact. Birth history, delivered on 29th of May 2029. She is term born, born by vaginal delivery, home delivery, and cried immediately after birth. Birth weight was 1 kg. History of hospital admission in view of low birth weight for 4 to 5 days. And there was no other significant birth history. Weight monitoring records are not available, and mother is not able to recall about weight gain in follow-ups. Growth and development. All milestones achieved till age. She is currently studying in class 12 and scholastic performance is good as she can do calculations, knows table of 12 and 13, and can read English, Hindi, and English language books. Immunization. She is immunized as per national immunization schedule till 10th year of age and BCG scar is present. Diet history. Her calorie requirement is 2100 kilocalorie per day. She is taking 1240 kilocalorie per day with deficit of 860 kilocalorie per day. And protein requirement is 75 gram per day and is taking 39 gram per day with deficit of 36 gram per day. Family history. She is firstborn child after 2 years of marriage life. Her mother age during marriage was 29 years and father age was 32 years. And second child is 15-year-old male child. His birth weight was 3.5 kg. Third child is 13-year-old female child with birth weight of 3 kg. Both siblings are having normal growth and development, gaining age appropriate height and weight. History of abortion of first 2 pregnancies at 2.5 months. First one was spontaneous and at 4 months due to hereditary hormone. There was no history of delayed puberty in both parents and no history of siblings' death. Socio-economic status is total 5 members stays in Kacha house with 2 rooms having 3 doors and there is no window. A source of water is tap water. And his father is painter by occupation and mother is domestic helper. Income is 22,000 per month. As per Kupuswamy classification, she belongs to lower middle class. And there was no history of child abuse and family separation. on examination.
Wait. No. Right. Very nice, Dr. Swadha. Is it the way you pronounce your name? Swadha. Am I
Yes,
right?
Swadha. Yes,
Yeah.
yes, sir.
Yeah. Please go. Very nice, nearly complete history. Please go back to your
Yes.
first slide.
Okay, sir.
Okay. How old is she?
17-year-olds.
But are you right in saying she's a 17-year-old child?
Yes, sir. As per mother and date of birth.
No, the reason why I caught you on the wrong foot is that always when your case is 17 years old, do not use the term child. Use the
Okay, sir.
term adolescent. Okay?
Okay, sir.
Instead of
Okay, sir.
saying, if I were you, I would have started the whole thing as 17-year-old
Yes.
adolescent female or adolescent girl.
Okay,
Okay?
sir.
Don't use the
Okay, sir.
term child for somebody who's 17 years old. That's
Yes, sir.
first. Go to the next slide. You have put two chief complaints. One is a very long one of not gaining weight. Another is an acute symptom. Okay, fair
Yes, sir.
enough. Okay, there are two complaints. One is related to height and one is related to menstruation, isn't it?
Yes, sir. Yes, sir.
Go next. Go to the next. Go to the next. Go to the next slide. You had mentioned that patient is apparently normal and had appropriate growth till 12 years of age. How did you come to the conclusion that she was normal and her growth was normal up to 12 years of age? What made you categorically start with an opening statement like that?
Sir, as per mother, she is gaining height as compared to her peer age group and her other friends. And she used to, as already mentioned, she used to stand at the back during prayers and currently, and which she used to stand at front row now.
The reason why I asked,
Yes, sir.
here is a mother who has got three children and all the three are adolescents. Am I right?
Yes, sir.
You could have simply compare the height of this girl with others. The one is 13 years old, isn't it?
Yes, sir.
The other sib is 13 years old, isn't it?
Yes, sir. Yes,
Girl
sir.
or boy? Girl or boy?
A girl child,
Girl.
13-year-old. Yes, sir.
Yeah. In fact, the best way to confirm that she is not growing as well as she should would be to ask the mother how is the height when compared to the other sibling. Did you ask that question?
Yes, sir. And she has no records of
No,
weight
she may
height
not have
recording.
records, ma. She may not have records. You
Yes.
don't expect her to have records in this socioeconomic status. In fact, affluent parents themselves don't have growth charts,
Yes,
right?
sir.
So
Yes, sir.
that may not be there. But a simple question, how she was now, at least now, can you tell me, suppose, did you ask whether this child's height is lower than that of the adolescent who's 13 years old and the one who's 15 years old?
Yes, sir.
Yeah, that's
Yeah.
what. That should be your
Yes.
correct answer. That
Yes, sir.
should be your correct answer. Now, the second thing is, what makes you say that this girl was apparently normal until 12 years? But that's very, very important. Very, very important because if it is going to be a story where this girl was completely normal at 12 years and then there is some faltering in the height, the etiology is different. Whereas
Yes, sir.
if you are not sure about normalcy at 12 years, the etiology is likely to be different. What made
Yes.
you categorically say she was apparently normal?
Sir, as per mother history.
Yeah, everything is as per mother history. Don't put the blame on the mother. This is one problem with postgraduates. You always, when when you are cornered, you will always say, this is what the mother said, this is what the father said. You must also remember the mother and father are not trained to give history. They don't attend programs like this.
Yes.
They are not trained to give correct history. You have to get the best of information from them. Now, what made you categorically say she was completely normal at 12 years?
She's attending height till 12 years of age. And
Yeah,
as
yeah.
per age groups, and his younger siblings, a male child is 15 years old currently. And as mother compared with her siblings' height, she assumed
Okay.
that he was
Okay. What about the weight? What about the weight?
currently is 33 kg.
No, no, 12 years. Was she all right? Was she reasonably okay, at least in appearance, in terms of weight?
Um, no,
Pardon?
sir. No,
Yes,
sir,
sir.
there was no record for weight.
No, record is not
Actually,
the
Monday
mother's
for
visual,
what?
mother's visual observations.
Okay. Sir, there is no gain in height or weight both after 12 years of age.
After 12 years, not
Yes, sir.
before that.
No, sir.
Sure.
Yes, sir.
Okay, that is one. Second, okay, that's a very nice point. I like your statement saying that she used to stand at the back during prayers because of feeling short. That's nice. That's a nice way of putting it. Okay,
Yes, sir.
and the other than that, there had been no other problems in the last 5 years, isn't it?
Yes, sir.
Okay. Now the second, you have straight away gone to the second symptom. And now, in the last 5 years, other than the bleeding per vagina, now,
Yes.
had there been any other illness in the last 5 years?
No, sir, there is no history of any illness or
No
hospital
illness.
admissions.
No illness. Okay.
Yes.
Okay. Any hospitalization so far?
No, sir.
No. Okay. Right. Then you started with the history of bleeding per vagina. Okay, fine. She attained menarche at 13 years, right? Cycles were a bit irregular, but she blood flow for 5 years, no excessive. Please go to the history of blood transfusion after admission. Did she receive blood transfusion? Is it?
Yes, sir.
Okay. 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 Go to the next slide. Go to the next slide. And history, other than this, nothing else had happened in the last 5 years other than this bleeding per vaginum and the lack of weight, the lack of gain of height. What
No, sir,
about
there
the
is no.
gain of height in the last 5 years? Weight.
Sir, at 11 years of age, she was weighing 30 kg, and
Hmm.
currently she is 33 kg.
So, is your history right saying that it is only height which is affected, or you should have added poor weight gain over the last 5 years? Yes or no?
Yes, sir.
Yeah, it may. Well, in what way it is important to know? See, there are three children who are not gaining weight. Three groups of children who are not gaining weight. One is the weight is normal, only height is affected. Second is both weight and height are affected. Third is weight is much more affected than height. What's your inference?
Yes, sir, height is much more affected than weight in this case.
Pardon?
In this case, height is much more affected than weight.
How do you know height is more affected than weight?
Sir, on anthropometric examination.
No, before history. We are in the history. We have not gone to the examination at all. That's why I stopped you.
Okay.
Now, mother would tell you, again, mother is the Supreme Court. Okay. She will
Yes,
tell
sir.
you, no, doctor, she's gaining weight, but she's not gaining height. One group. Second group, she's neither gaining height, neither or weight. Third group, she's putting on too much of weight, but she's not gaining height. What are the three groups? Can you interpret? Can anybody put in
Sir,
the chat box,
currently they are
students who
more
are listening?
Currently they're more concerned about not gaining height than.
No. You tell me the interpretation of these three scenarios. I'm again repeating it. This is
Yes, sir.
fundamental of growth and development. One, mother says, my child is not gaining weight, height for the last 5 years. but she is
Yes, sir.
gaining weight normally. That is mother one. Mother two, doctor, neither the child has put on weight nor has the child put on height in the last 5 years. Third, doctor, she is putting on weight too much, but she is not becoming taller. What is your interpretation? That's all I'm asking. Any PG can put in the chat box also.
The third one, she is gaining weight but not gaining
No, no,
height.
no, no. You interpret 1, 2, 3. First one,
Okay.
mother says weight gain is okay, only height is affected.
Sir, it is suggestive of chronic disorder.
One, it could be a chronic disorder.
Chronic.
Chronic disorder, weight also will be affected, ma. Strong possibility of an endocrine disorder, ma. When height is only affected, weight is not affected. Or past malnutrition in the child recovering. Otherwise, weight cannot be affected in simply an endocrine disorder. One.
Yes, sir.
Two, weight is also affected, height is also affected. It may be a chronic nutritional problem. Chronic nutritional problem. Third group, height is affected, weight is more. Hypothyroidism. Hypothyroidism. Commonest. Okay. That is
Yes,
why I
sir.
wanted you to tell us which group does this child belong to. Which group does this child belong to?
Sir, height is more affected than weight.
Yeah, both are affected, but height seems
Height
to
is
be.
more
From the
affected.
history, the mother feels the height is more impaired than weight gain.
Weight.
That's
Yes.
all. Okay,
Yes.
in which case it could be an endocrine problem or it could be a chronic disease. Yes or
Nutrition.
no?
Yes, sir.
Okay, that is it. Then you had mentioned few other symptoms, irritability, easy fatigability, decreased sweating, cold intolerant, dry skin. What does this mean? What is your interpretation of these symptoms?
Mm.
Yes, Dr. Swadha? Yes,
Sir,
please.
it can be suggestive of any malnutrition. Easy fatigability and
Malnutrition.
irritability can be
Do,
suggestive
do,
of
do,
malnutrition.
do you get cold
Matlab,
intolerance,
chron-
decreased sweating in malnutrition and malnutrition at 12 years of age? How common is it?
no, sir, irritability and easy fatigability are suggestive of chronic nutritional
What
deficiency, and
I'm
cold
saying, 12
intolerance,
years.
dry skin are
Okay.
suggestive of endocrine.
Endocrine and probably a thyroid.
Endocrine.
Hypothyroid
Yes.
status. Okay, quite possible.
Okay.
Quite possible. Okay, or
Yes.
all these symptoms could also occur in an adrenal insufficiency, plus or minus the hypothyroidism. For example, easy
Yes.
fatigability is one of the earliest signs of Addison's.
Yes.
Okay, right?
Yes.
Decreased sweating also
Yes.
could be a sign of adrenal insufficiency, right? And of course, hypothyroidism. Okay, go to the next slide. Next slide, please. Yeah, then recurrent fever, cough. Okay, chronic disease. Okay, hypoglycemia. How will the mother give you a history of hypoglycemia?
So there was no history of hospital admission. There was no history of seizures, or there's no history
You
of
should say
lethargy.
hypoglycemia. There's
Yes,
no
sir.
hospitalization. You should mention. Okay,
Yes.
bruising. Okay, for bleeding disorders, liver disease. Why did you ask jaundice, abdominal distension? Because of bleeding, is it? Okay,
Yes,
fine.
sir.
Next one. Next slide. Next slide. Cyanosis, dyspnea, suggestive heart disease. I think I wouldn't have asked. Edema, hypertension. How will the mother give a history of hypertension? I don't think that's relevant. Blood transfusion, okay. Intracranial hypertension, okay. Drugs like steroids, anti-epileptics, okay, fine. Next one. Next slide. Yeah, okay. Now, other than this, did you ask the mother what they have done about this problem in the last 5 years? Any intervention, any investigations done?
No, sir. She was
No. And
she was only
more,
admitted for 4 to 5 days.
okay, more importantly, did you ask about school performance? Is it important?
Yes,
Why
sir.
that's important?
Sir, to rule out mental retardation or
Not mental retardation. Hypothyroidism will cause poor scholastic
hyper
performance.
poor scholastic.
Poor scholastic performance. Unlike hypopituitarism. Hypopituitarism, usually the mentation IQ are well preserved. Well preserved. Okay, even if it's an
Yes,
adrenal disorder causing an endocrine short stature, it wouldn't affect the school performance. Whereas your hypothyroidism will definitely impair the intellect of the child and cause deterioration in school performance and lethargy, excessive sleepiness. I would have asked for excessive sleepiness in this child.
yes,
Okay?
sir. There was no history of it.
Perhaps,
Yes, sir.
perhaps I would have asked, inquired about polyuria, polydipsia. Okay?
Yes,
Ruling
sir.
out a renal tubular disorder or a chronic renal disease or a diabetes insipidus or mellitus.
Yes, sir.
Okay? Right.
Yes, sir.
Anything significant in the birth history, there is something very significant. It was a very low birth weight baby. Okay, that's a very significant history you have here. Next slide. Next slide, please. Growth and development, all milestones achieved till age and performance has been good. Good. So there is no intellectual disability in this child, and there is no
Yes.
deterioration in school performance over the last 4 years. Am I right?
No, sir. Yes, sir.
That you should mention. The last 4 years, nothing has gone wrong with the development on school
Okay.
performance. What about school
Okay, sir.
absenteeism in the last 4? Always, adolescents, you should ask about school absenteeism. That's an important parameter for assessing chronic disease. Next slide,
Yes.
please. Next slide, please. Immunization, okay. Now, calories, protein. Does a 17-year-old girl require 75 grams of protein?
Yes, sir. As per expected weight, 1.5 gram per kg per day I take.
Oh, you put it as okay. But I thought the ICMR recommends around 40 to 60 grams for an adolescent girl. Okay, fine. You are putting a higher. Nowadays, the protein requirements are going up. Okay,
Yes.
fine. Fine. Okay. Go ahead. Next. Family history. Okay. The other two siblings are perfectly all right, is it? They are having
Yes.
normal development, school performance, everything. Okay. Is there a consanguinity?
No, sir. There was no history.
No consanguinity. Next slide. Abortion. Okay, next slide. History of, wait, history of delayed puberty in both, wait. Please go to the previous slide. Please go to the, yeah. No history of delayed puberty. Okay, right, next slide. 5 members, okay, right. Okay, what about the treatment over the last 5 years? They have not sought any investigation, any treatment so far?
No, sir.
Okay, next slide. Well, before you go to the examination, what is the summary of your history? And I request Dr. Biswal to take over and discuss the
Swadha,
of history. Dr. Biswal, please.
yes, Dr. Swadha,
Yes, sir.
tell the history in a nutshell about the history and summarize the history.
Yes, sir. A 17-year-old female child presented with complaint of not gaining
Don't
height
say
since
child again and again. You are saying
adolescence.
child. Thank you.
Sir.
Bad habit, die hard.
17-year-old adolescent female girl presented with complaint of not gaining height since 5 years and bleeding per vagina since 12 days with positive findings of increased irritability and cold intolerance and decreased sweating all over body and with there was no significant family history with significant birth history of IUGR and there was no history of hospital admissions or any recurrent admission and as per growth and development she attained all milestones as per age and there was no other significant family history till now.
Yeah. Having a good scholastic performance.
Yes, sir.
That's one point. And regarding this abortion, there was one spontaneous abortion, one was hydatid for more.
Yes, sir.
So there are two problems, particularly hydatid for mole is there. So how do you account for it? No, anything coming to your mind? One is spontaneous aversion, one is hydatid for mole. Is it related to your case when there is spontaneous bleeding per vagina? Can you correlate anything? Anything?
Sir,
Because yes, continue.
sir, hormonal imbalance in mother, most commonly hypothyroidism, and
Yes, one is the some hormonal imbalance. Second thing, maybe any genetic cause we have to
genetic
see.
defect. Yes, sir.
That's the thing. And regarding,
Yes,
I
sir.
want to tell regarding the immunization, you
Yes,
have
sir.
told at the age of 10 years, she has been given the routine immunization at the age of 10 years. Now she
Yes,
is
sir.
17 years.
Yes, sir.
So she should take the vaccination at the age of 16 years.
Yes, sir.
Which,
TD.
which vaccine?
TD, sir. TD. Tetanus.
So it is
And
missed.
HIV vaccines still.
TD, the national immunization schedule. So it has been missed the TD vaccine also.
Yes, sir.
You have to give importance to that. So there may be some hormonal imbalance whenever talking of something bleeding per vagina and there is a short stature,
Yes, sir.
which are most likely a chronic problem. Maybe endocrine, as Balasa was telling, maybe endocrine, hypothyroid, the commonest being,
Yes,
because
sir.
cold intolerance and there was some, but the performance, school performance is good, scholastic performance is good. So
No, sir. There
summarizing,
is. Yes.
so having the good scholastic performance,
Yes,
yes or
sir.
no? Yes.
Yes, sir.
Okay. So you are not dealing with a case of what is the most probably we are dealing with, or which system you have to give importance?
Sir, endocrinal.
Okay. Let us continue then.
Yes, sir.
Yeah, just a minute, just a minute. See, at the end of history, can you list the problems that you identified from this history, Dr. Swadha?
First, DD will be chronic malnutrition. And the
Chronic
second,
malnutrition. Chronic, see, two things. One thing you must remember. How
yes,
many cases of chronic malnutrition causing short stature have you seen at 17 years? Please tell me. Exceedingly rare. You don't get unless there is something like a chronic disease. Okay, a
yes, yes, sir.
malabsorption, celiac disease, chronic HIV infection, chronic tuberculosis, immunodeficiency, chronic cardiac disease. You do not get chronic malnutrition causing short stature and growth retardation in adolescence. Very important, very important. Here is a girl who was completely normal up to 12 years
Yes,
with
sir.
no family history of short stature or intellectual disability, no consanguinity. Birth weight is 1 kg, but she seems to have caught up in terms of growth and development and has
Yes,
been developing normally, doing very well in school. Has started, has had the problem of growth retardation, mainly in the form of lack of height gain. Okay.
yes,
In
sir.
addition to also not gaining appropriate weight as per the history, without
Yes, sir.
retardation in intellectual performance, with a new problem of though she attained menarche at 12 years, she is now having menorrhagia for over 12 days with no history suggestive of a systemic bleeding diathesis, either due to a vessel wall disturbance or due to a platelet disturbance or a coagulation disturbance, localized uterine bleeding.
Yes, sir.
Okay. The whole thing looks like some endocrine cause of short
Yes, sir.
stature, which is associated with dysmenorrhea. What do you think are the common causes of dysmenorrhea in a 17-year-old adolescent? Sorry, not dysmenorrhea, your menorrhagia.
Sir, hypothyroidism and polycystic ovarian disease.
Yes, yes. But usually polycystic ovarian disease is more often seen in obese adolescents who have got metabolic syndrome with acanthosis nigricans, right? But not in
Yes, sir.
those who are not putting on weight or height. But however, that possibility has to be thought of. One, two, is bleeding diathesis completely ruled out with this history? Which
Yes.
bleeding diathesis can fool you with this sort of presentation? Girl, I'm giving you a clue. Can anybody put in the chat box? Not easy to diagnose. Von Willebrand's disease, notorious in girls like this, it can present as menorrhagia. First time presentation itself can be menorrhagia.
Menorrhagia.
Difficult to diagnose unless you investigate properly.
Yes.
Okay? Von
Yes.
Willebrand is not ruled out in this girl. Okay?
Yes.
It could be
Yes.
something like that. Something like, or some rare factor 13 deficiency, okay, can also present like this occasionally, very rare. Or dysfibrinogenemia, afibrinogenemia can present at this age. So usually they present much earlier than this, and you can't explain the short stature if there is a bleeding diathesis. So with short stature around, you would always think of an endocrine problem causing a menorrhagia like this. That should be your interpretation.
Yes.
Okay?
Okay, sir.
Please go ahead. Dr. Biswal, you want to ask anything more in history before we...
Swadha, you should remember that you are talking of chronic nutritional problems. That
Yes,
is
sir.
usually up to the age of 5 years, not after that still. If it is after that, you should not, it is not due to the nutritional issues.
Okay, sir.
As it is being discussed, it is other than the nutritional issues. You should remember that point. That's the basic thing we
Yes,
should
sir.
give. Okay, continue.
Yeah.
On examination, child appears dull with puffy and expressionless face. On vital examination, temperature is 98.2 degree Fahrenheit, measured at right axillary region. Pulse rate was 76 beats per minute, regular, normovolumic, no radioradial radiofemoral delay. Respiratory rate 20 per minute with equal chest rise. BP is 100 by 70, which is 58th percentile, measured at right upper arm. And SpO2 was 98% on room air.
Dr. Swadha, two
Yes,
or
sir.
three suggestions for improvement.
Yes.
Always in general examination, pediatrician should always start with an opening statement like this. These are the following points you should stress when you make an opening statement in the general examination. One, is this adolescent looking well or ill? Two, if she is ill, whether she is acutely ill or chronically ill.
Yes.
Three, is she conscious, alert, oriented, and cooperative for examination? Four, what are the arresting or alerting signs? For example, in this girl, 17-year-old, if I find she is very short, I would say that in my first sentence, not when I'm talking about anthropometry. If she is obese or she is marasmic, she is wasted, I will say that in my first statement. Comment number one. To comment number two. Third
Yes.
one, please do not use the term dull in pediatrics. The English meaning for the word dull is somebody with low intelligence, idiotic, or somebody who's intellectually retarded.
Yes.
So please do not use the term dull. You say appears lethargic.
Yes.
Puffy. Where is the puffiness? In the face or where?
Sir, lower eyelids.
You say puff, you say periorbital puffiness.
Yes.
Okay. And
Yes.
expressionless face. I don't know what you mean by expressionless face. What do you mean by expressionless face? What expression did you expect from her? I don't
Sir,
know. It doesn't convey
yes,
anything to me. I don't understand what you mean. What do you mean by that?
yes, sir.
Okay, avoid using words or phrases which don't give you correct meaning and which are not understood by others.
Yes.
Okay, right. Go ahead.
On anthropometric examination, weight is
Does
30
she look
t.
short right on examination inspection?
Yes, sir.
Does she look wasted or obese or fairly nourished?
Um, Sir, fairly nourished
You
on
could have mentioned
inspection.
that. Could have
Yes,
mentioned
sir.
that. Okay, fine. Go ahead.
Weight is 33 kg and expected weight is 51 kg. Weight for age is less than third percentile as per IAP growth chart. Height is 120 centimeter against expected of 157 centimeter. And as per IAP growth chart, height for age is less than third percentile. BMI is 22.9 kg per meter square. Expected is 22 kg per meter square. Her mid-parental height is 147 centimeter. Upper segment and lower segment ratio, which is 0.9, which is normal, and upper arm span is 126 centimeter.
So you mean to say the arm span is more than the height by 6 centimeters? Okay, it
Yes, sir.
doesn't mean anything. Now, what is the interpretation of this mid-parental height and your height? You have plotted the details in a growth chart?
Yes, sir.
Show me the growth chart. Yeah, it's very difficult to see because it's so small. Okay. What is your interpretation of this?
Sir, in this case, height age is 7 year 4 month and weight age is 11 year 6 month. And then so height is more affected than weight and has BMI is normal, nearly normal.
Now, what about the mid-parental height? What is your interpretation of the mid-parental height?
Mid-parental height is low as expected as her height is 120 centimeter and expected mean parental height is 147 centimeter.
So no. What I'm saying is she falling 8.5 centimeter below the mid-parental height or not?
Yes, sir.
Yeah. So okay. Now go to the growth chart again. Go to the growth chart again. Okay. Please describe the growth chart of this girl and give your interpretation.
This is IAP growth chart. Currently, I have plotted. Currently, her weight is 33 kg, which is actual weight, and her expected weight as per 58th percentile is 51 kg. So height weight for age will be 11.6 years, and this actual height is 120 centimeter. Her expected height is 161 centimeter, and her height age will be 7 year 4 months.
Okay. What is your interpretation? What's your growth chart diagnosis at this point of time?
Sir, here weight age is more than height age.
What is your
And
diagnosis? I'm straight away asking, what is your interpretation?
sir, chronic chronological age is
Does
more
she
than
have
weight.
short stature or
Yes, sir.
not?
Yes, sir.
Yes, that is number. Why do you say she's got short stature?
As weight for height is height for age is less than third percentile.
Okay.
And
Do you think this is constitutional or pathological?
sir, it's pathological. As she not
Why do you say
attend.
this is pathological?
Sir, as she not attend adult height till 17 years of age.
Far below this much. This much is, and the parent. What is the father's height and mother's height?
Sir, father height was 161 centimeter and mother height was 148 centimeter.
This is pathological because it's definitely falling way below the mid-parental
Yes.
height,
Yes,
right?
sir.
My
Yes, sir.
next question is, if this is, do you think the 1 kg birth weight has anything to do with this?
Sir, IUGR can be is one of the cause of short stature.
Hmm. But does it cause the problem after 12 years? You said If your height parameters are available earlier, okay, then
Yes, sir.
and her weight seems to be fairly okay, earlier. So you can't put the blame on the 1 kg birth weight, 1
Yes.
kg birth weight. Okay,
Yes, sir.
because usually they all make up, even if it is an IUGR infant, the growth pattern reaches normalcy at least between 2 to 4 years of age. Until 2 years, they will definitely lag behind. After that, they make up, and after 4 years, they make up with other normal children. Okay,
Okay, sir. Okay, sir.
right. Okay.
Then,
Then,
Swadha, you did not explain, Swadha,
Yes, sir.
you did not explain this target height range. When you are interpreting the growth chart, you should
Yes,
have
sir.
explained the target height range. In between what centimeter it is the range is there. Where have you plotted it? How you have plotted? Okay, that part also you have to see that you have calculated MPH.
Yes, sir.
But,
she has not
you
mentioned the MPH in the growth chart. It's okay, but she mentioned. You
so
should.
you should.
You're right, sir.
uh,
You're right. Absolutely right. You should plot it. Agreed.
okay, next one.
Hmm. What about the bone age? 1 minute. Since you have done a bone age,
7 years.
interpret
7 years,
this
sir.
X-ray and give the bone age.
Sir, it's 7 years.
How did you come to a conclusion it is 7?
Sir, I compared the normal X-rays and
No. How many? See, usually it is age plus 1 carpal, the number of carpal bones. In fact, for a 17-year-old, you expect all the carpal bones to be present. But here it looks like she has only around 1, 2, 3, 4, 5, 6, 7, 8 carpal
8.
bones, which itself is clear that there is a delay in bone age. Though, if
Yes,
you
sir.
ask me whether I know how to interpret bone age correctly in a 17-year-old, I would say I don't know. Okay, I will only request the help. Dr. Biswal, if you know, please tell. I don't know how to interpret the bone age in an adolescent. I will only request the help of a
Actually,
radiologist.
at the age of 12 years, all the carpal bones should be there. There are 8 carpal bones. So I think what you told that I will compare with the normal X-ray.
Yes, sir.
Where you get the X-ray, normal X-ray? That is not the way. Comparing with the normal X-ray. You have to see
Yes.
roughly. There is one atlas,
Hmm.
Perlic
Okay.
Resilience Atlas or something like that. There is some atlas. It is being seen from the atlas, or there is
Yes, sir.
also another method I have forgotten. But roughly, if there are 5 bones, 5 carpal bones, you have to add 1. That means it is 6 years. It is,
Yes,
I
sir.
think you are having in this child, when you do the left X-ray study, left wrist X-ray, there may be 6 bones. 6 plus 1, it is 7 years. Can you tell how many carpal bones are there?
8, sir.
8.
Yes, sir.
There are total 8 carpal bones. Total, there are 8 carpal bones. If it is 8 carpal bones, all the carpal bones are there. So it is normal. Yes or no? I think
Sir,
it is the radiologist who has given you the bone age, I think 7 years.
They use the Tanner atlas or the Grulich pile atlas. That's what they use. So I don't know. I don't know all the components. I will only ask the radiologist. Okay. As you rightly said, age plus 1 is the number of carpal bones in the wrist. That's a rough
yes.
formula.
Yes, exactly. So it is 7 years. If there are 8 carpal bones, means at the age of 12 years, all the carpal bones there. So 17 years, all the carpal bones are there. That means it is okay. Okay. I think
Yes, sir.
it is the radiologist report. They have given 7 years. Uh, what I think.
Yes, sir.
There
Yes.
must not be 8 carpal bones.
Fine.
Okay.
Please go
Okay.
ahead.
On head to toe examination, hair appears brown in color, thick and good in quantity. There's an increased amount of hair over forehead, depressed nasal bridge, lid puffiness, bilateral lid puffiness, hyperpigmented patches with scaling of skin over left side of face. There was multiple caries over tooth and neck appeared short. There's hyperpigmentation of nape of neck, increased carrying angle, cuboidal valgus. Skin appears dry, rough, and lusterless, and finger and toes are short and palm are thick, and there is cracked sole.
Was there any webbing of the neck?
No, sir.
Any widely spaced nipples?
No, sir. Chest.
Okay. Show me you have the picture of cubitus valgus? No. Okay. It's okay.
No, sir.
Okay. Go ahead.
On Tenet staging, breast appears stage 3 and pubic hair stage 1. And on examination, pallor present and grade 1 clubbing. There was no cyanosis and lymphadenopathy and no other significant findings on head to toe examination.
How did you come to conclusion there is clubbing? Because the Shamrat's sign is not there. Nice. You can see the gap between the nails.
Sir, grade 1, there is a puffiness of nail beds.
Grade 1 is actually fluctuation. It's not puffiness. Grade 1 is only fluctuation of the nails, very subjective. Here the Shamrat angle is well preserved. I wouldn't call it clubbing at all. Okay?
Yes.
Go ahead.
Yes.
Only if you see, you can see my hand.
Yes, sir.
Okay, this same, it is preserved. I don't think there is any clubbing at all in this child. Fluctuation is the sign of grade 1 clubbing. Okay?
Okay.
Not
Yes.
fullness. Yeah.
Okay. On systemic examination, per abdominal examination, there was no significant abnormalities and inspection. There was abdomen was soft, no distension, no organomegaly. On percussion, there was no significant finding, and bowel sound was present. On central nervous examination, patient is conscious, oriented to time, place, and person, and all cranial nerves are intact. Tone was normal, and grade 4 power in all 4 limbs, and coordination was normal. And there was a reflex and sensory system examination was normal. On respiratory system examination, there was
cardiovascular system normal. Anything else?
no. Yes.
Did you examine the fundus?
No, sir.
Why should you examine the fundus in a child with short stature? What is the importance? Papilledema, central causes, space occupying lesions. Okay? Or even
Yes.
hypertensive, retinopathy, hemorrhages, all could give a clue to the presence of a renal disease causing short stature, etc. Okay? Go ahead.
Yes.
Please go ahead.
And summary. Patient admitted with complaint of not gaining height since past 5 years and bleeding per vagina since 12 days, associated with easy fatigability, decreased sweating, cold intolerance, irritability, and constipation, with no history suggestive of chronic systemic illness or no history of drug intake, past history of irregular menses since last 1 year, with birth history of IUGR and with normal growth and development, with nutritional deficit of 860 kilocalorie and 36 gram of protein per day. Family history reveals normal short stature in parents and siblings, with anthropometric findings of bone age is less than height age, which is less than weight age, and with normal BMI, with below expected mid-parental height, with lusterless skin, short neck, short finger and thick palm, and pallor, and grade 1 clubbing on examination, and with no other significant findings on systemic examination.
Grade 1 clubbing, I don't agree. Right, thank you.
Yes, yes. This case is approached as a case of short stature and history and examination findings suggestive of most probably endocrinal disorder, and which most common cause is hypothyroidism or growth hormone deficiency, which is further diagnosis in favor of endocrinal disorders. As there is normal BMI, which will be low in chronic nutritional anemia. Bone age is less than height age, which is less than weight age, and less than chronological age. Difference between height age and weight age is more than 2 years.
Agreed. Agreed.
It is further confirmed with investigation. Lab findings suggestive of hypothyroidism with iron deficiency anemia. So final diagnosis will be short stature with hypothyroidism with iron deficiency anemia.
Okay. Dr. Biswal, you can
Yes,
discuss
sir.
before we discuss the case fully. Dr. Biswal?
Yes. Dr. Swadha,
Yes, sir.
you have put the diagnosis of hypothyroidism,
Yes, sir.
and it is acquired in nature. Okay.
Yes, sir. Yes, sir.
There are any, you have told this cubitus valgus, then the webbing, there is some other features of the, in a girl child. What are the other possibilities can you think in a short stature?
Sir, as she is a girl child, I can think about genetic disorder, most commonly Turner syndrome, and growth hormone deficiency.
So coming to the Turner, how will you contradict when it is
Sir, there was no history of delayed puberty, and the patient gained height till 12 years of age. And in Turner syndrome, there will be poor height since infancy, and there was no history of cardiac abnormalities. That most probably as a coactation of is most.
from the clinical history, she was having bleeding,
Yes, sir.
PV, bleeding per
Yes.
vagina.
Yes, sir.
What about in Turner?
So there will
There
be
is
streaks ovary on
okay. They're
in
usually
primary amenorrhea.
they're having the amenorrhea.
Yes.
Okay. In the latter part of the story, it was looking like Turner, but usually from the history and from the other findings, it looks unlikely. Okay.
Yes, sir.
Yeah.
Yes.
Third thing, you are telling the growth hormone deficiency.
Yes, sir.
Why you are telling it is a growth hormone deficiency at the age of 17 years? How? What are the usual causes of the growth hormone? You are telling it is a central one or the peripheral one, or how to classify it? Because when it is a congenital growth hormone deficiency, or the
Yes, sir.
from the very beginning.
Mhm.
So, what are the usual causes? Usual findings in the child?
Sir, poor height gain since infancy in growth hormone deficiency, and
Then, in
and
growth hormone deficiency, what are the things? What is the history usually? And there are midline defects. Okay.
yes, sir.
There are usually midline defects, and they are having the persistent jaundice also. They are having the hypoglycemia. All these are seen, but it is not there. It may be acquired one. Why there is a acquired one growth hormone deficiency?
Yes.
But with the cause in the pituitary or cause in the hypothalamus, what do you think? Or it is not the growth hormone deficiency? Can you tell it?
Sir, in case of pituitary or hypothalamus involvement, there will be a decrease in all pituitary hormones like ACTH, growth hormone, and thyroid hormone. So it can be peripheral cause of growth hormone deficiency.
So the thyroid is absent. Yeah. So thyroid symptoms are there, but a growth hormone deficiency, basically at this age, the acquired conditions, they usually the tumors, they unless you do an MR focusing on this thyroid or this hypothalamus, it is very difficult to pick it out, and it is also unusual for this presentation. Okay.
Yes.
Yeah. Then if it is a hypothyroid state, okay, you are telling the TSH is quite high,
Yes,
more than
sir.
100.
Yes.
What about the FT4? Have you done the pre-thyroxine and all those?
No, sir.
Okay. So do you think is it helpful, or why it is required or not? Only the TSH will help you.
No, sir, it is required. It is to differentiate peripheral and central cause of hypothyroidism.
Then what are the problem of doing it? Pre-thyroxine or total thyroxine? Why it was not done? Can you tell what are the financial issue or something else?
Yes, sir. There was financial issue. We advised, but they refused for further
Okay,
investigations.
okay. And when we are talking of, we are thinking of some intracranial space occupying lesion, there is a possibility.
Yes, sir.
So you should not forget doing the fundus exam. That is a
Yes, sir.
very common test. You could have done it. So particularly in the cranial nerve examination and particularly thinking of a differential diagnosis, it should not be forgotten. Okay,
Okay, sir. Okay.
that's one thing. Okay,
Okay.
so okay, Balasa, you can take.
Yeah, Dr. Swadha,
Yes,
let
sir.
us go back to the fundamentals now. What is the definition of short stature?
Sir, height for age below
Can you define
height
short stature?
height for age below third percentile or not
Third
not.
percentile. No. That's not the correct answer.
Sir, there is actually rule of 5 for defining short stature.
If only two standard deviation are less than the 2.3 percentile. It's not the third percentile. If you go by the definition,
Okay, sir.
any height or length which is two standard deviations or more below the mean height or length, and that's not enough for the same sex and chronological age in a given population. That's the definition of short stature. And anything which is less than two standard deviation is also below the 2.3 percentile. 2.3 percentile. That is what you should remember.
Yes,
Now,
sir.
what are the two most common causes of short stature? I'm asking exam-oriented questions. The exam, they may keep a short case like this and ask you viva questions. What are the most common causes of short stature? Anybody can put in the chat box also. Number one is familial or
Nutrition.
genetic. Number two is constitutional.
Yes, sir.
These are the two most common causes of short stature. It is not pathological short stature. It is only familiar or genetic
Yeah.
or constitutional.
Constitutional.
The two
Yes.
groups are the most common causes of short stature. My next question to you, how do you arrive at the mid-parental height? And why do you have two different calculations in mid-parental height? One for girls, one for boys. You add 13 to boys, but you subtract 13 for girls. Why?
Yes, sir.
Anybody can put in the standard exam question I'm asking. Very simple. That is the expected difference across the world between a boy and a girl. That is why you deduct 13.
Yes,
Okay?
sir.
That
Yes,
is
sir.
something which you should know. Right?
Yes, sir.
Now, when you have a child who looks like being short, the first thing you do is to do an assessment of the mid-parental height. If it is 8.5 centimeter below, then definitely it is falling below the
Third percent.
expected percentile. Okay?
Yes, sir.
Right? In
Yes.
general, any height which is less than the first percentile, that is likely to be called as extreme short stature and definitely needs an evaluation. Definitely. That is height less than the first
First
centile.
percent.
That is
Okay,
very,
sir.
very important. Okay.
Yes, sir.
Then, of course, depending on the speed, it is not only the single measurement, it is also the growth velocity. You must remember the normal growth velocity 50 centimeter at birth, then 75 at 1 year.
Yes,
Okay.
sir. Yes, sir.
Then 2 to 5 years, the velocity is around 5.5. 4 to 6 years, it is 5 centimeter per year.
Yes, sir.
And if it is 6 years to puberty, it is 4.5 for girls and 4 centimeter for boys.
Yes.
That's what. Okay. Then
Yes, sir.
the other important thing you must remember is the difference in the growth velocity in boys and girls. Boys start growing later than girls. The growth velocity increases due to sex hormones and due to puberty at 10 years itself in the girls and
Yes,
finish
sir.
early. Whereas boys start gaining weight and improvement in growth velocity only by around
13 to 14
yeah,
years of age, peak height lost.
12 year, 10 and 12.
Yes.
Then the other point that you must remember, you have to find out the bone age. That is where you use I forgot the name, Tanner's
Tenor Whitehouse stage.
Tanner Whitehouse. Yeah, I don't remember. And the Grulich pile atlas. You have to discuss with the radiologist.
Okay, sir.
Basically, there are three things that can happen when you do an X-ray. I'll give you a choice. The bone age is markedly delayed. Bone age is markedly delayed.
Delayed.
What do you think is the cause for short stature?
Endocrinal disorders.
Is that the commonest?
And,
Constitutional also. That's what is important. Even in constitutional short stature, the bone age may be delayed. Of course,
okay, sir.
endocrine, thyroid, yes, bone age will be delayed.
More affected than height age.
Bone age is normal. Normal.
Yes.
Short
Yes, sir.
stature is there. What is the diagnosis?
Sir, any systemic disorder?
No, commonest is familial short stature. Familial short stature. Okay? Bone age is delayed, it is constitutional. Bone age is normal, it is likely to be familial. Okay? However,
Okay,
even
sir.
in turners, bone age can be normal. Where will you get advanced bone age in short stature? Advanced bone age, rare. Anybody can put in the chat box? Everything is advanced. Precocious puberty, hyperthyroidism. In both these conditions, bone age will be advanced. Whereas a
Yes, sir.
delay, characteristically, you get in constitutional delay, sometimes in hypothyroidism also. Sometimes in hypothyroidism also. Right? Okay.
Okay, sir.
And when it comes to short stature, the first question you should ask whether this is a normal variant. Do you think this is normal variant or constitutional or genetic in this child?
So it's a pathological.
Absolutely pathological. Why? Why?
Sir, as a
It's falling much below the mid-parental height.
mid-parental height.
The parents are not short.
Yes, sir.
Okay. And
Yes, sir.
she has also got a menorrhagia. Right? So this is not a normal variant. This is definitely pathological. Pathological.
Yes. Yes.
Now, if this is pathological, you rightly said it is likely to be endocrine because of delay in bone age. Okay.
Yes, sir.
Other than that, could this be a chronic systemic disease? And which chronic systemic disease can easily be missed in short stature? Anybody can put in the chat box? The most commonly missed cause of a systemic disease causing short stature is celiac disease. Celiac disease, particularly in the northern parts of India. Northern parts of India. Of course, the other causes include, your malabsorption syndromes, cystic fibrosis, immunodeficiency. Okay, child
Yes.
was got of chronic vasculitis, etc. Okay, chronic
Yes,
renal
sir.
disease, etc. Of course, you always think of a genetic cause when there is dysmorphism, okay, developmental delay, neuropsychiatric problems, learning disabilities, etc. etc.
Yes.
Okay, any facial dysmorphism which is not there in this girl should also give you a clue that this is a problem which is genetic. or endocrine. Of course, a good head to foot examination looking for clues like goiter, like webbing of the neck, cubitus valgus. Okay,
Yes, sir.
suggest a Noonan syndrome or even your Turner syndrome, Klinefelter syndrome, etc. must be looked into. Of course, genital examination is a must for clinical diagnosis. So, when you have a short stature, Dr. Swadha,
Yes, sir.
how do you proceed to investigate?
Sir, start with basic level investigation like CBC to rule out chronic
How does
nutrition.
CBC help you in the diagnosis of short stature?
Sir, to rule out any chronic anemia.
Excellent. Chronic anemia, right?
And
Could give
And-
rise to short stature. You can give something like congenital aplastic anemia may be associated with short stature, right?
Yes.
Hemolytic anemia, chronic disease can result in short stature. Agreed.
Yes.
Then
RFT to rule out any renal disease, renal tubular acidosis, or chronic renal
think of
failure.
if you think of a chronic inflammatory disorder like inflammatory bowel disease, systemic arthritis, etc., ESR, CRP might be warranted.
Yes.
Urine routine analysis, starting from simple diagnosis of diabetes mellitus to isosthenuria, low specific gravity urine in chronic renal failure, renal function test, metabolic acidosis, then free thyroid, FT4 and TSH, okay,
Yes, sir.
blood
Yes, sir.
sugar or HbA1c for diabetes mellitus, right?
Yes, sir.
Liver function test for any chronic liver disease are a must. Okay?
Yes.
And
Yes,
then
sir.
is the bone age estimation. Then, of course, if you think of a chromosomal disorder, karyotyping is a must. Then, of course, if you are suspecting a central nervous system problem or a pituitary problem, an MRI may be required, right? And of course, genetic testing, specialized endocrine testings, which we are not going to discuss now, may be performed. Okay?
Yes, sir. Yes.
Dr. Biswal, you want to add anything?
No, actually, I want to stress upon this celiac disease. When your patient is having short stature with anemia is quite common in celiac disease. You must think of that also. Particularly
Yes,
the bleeding may not be there, but anemia is quite common in celiac disease. That's a point to well taken up. Then, as usual, we have to see for the common genetic conditions. If as a theoretical question, theoretical discussion. So, what are the usual things we have to see? Again, the common things we should not forget in our area, the chronic condition like the sickle cell disease, having their being stunted, or it is a thalassemia and all those. So we should also think of that also.
yes, sir.
Okay. Sir, you want to add anything else or anyone else wants to add anything? Dr. Motwani, you want to add anything? Hello?
Regarding the management.
Doctor, you may stop sharing the screen. Of course, iron deficiency anemia, you require peripheral smear examination if necessary, serum iron bending capacity, and also stool for occult blood, and also stool for parasites. And Sir said, once there is severe anemia, you'll have to think of a GI cost like celiac disease or, protein losing enteropathy and things like that. Okay? Right. Please stop sharing. Please stop sharing your screen, doctor.
Dr. Swadha, please stop sharing.
Okay.
Yeah, switch on your video. Dr. Naresh, you want to add anything? Naresh?
Mr. Yogesh, can you unmute Dr. Naresh Motwani, sir?
Hello.
Sir, I unmuted all, sir.
Okay.
Yeah. Nothing to add, sir. A nice case discussion. It was a wonderful presentation also by Swadha. And
Excellent, excellent, excellent. Very well done, Dr. Sudha. Don't
Thank
get
you, sir.
rattled. I had to necessarily cross-examine you to improve your very good presentation. It was a good presentation. Well done. Okay,
Thank you,
don't get disheartened. You will get
Yes, sir.
75% if you present like this in the exam.
Thank you, sir.
Well done, Swadha. Keep it up. Definitely you can improve. Eh?
Yeah.
So,
Naresh,
yeah.
Naresh, you want to add anything? Anybody, any questions you can put in the chat box? We'll try to clarify. Sandeep?
Yes, I am looking at any questions if there are any in the chat box. Yes, sir. So there are no questions. So on behalf of Bhilai Academy of Pediatrics, we extend our heartfelt thanks to everyone for making this PG clinic a success. Our sincere gratitude to our distinguished experts, Dr. Balasubramanian sir, for his invaluable insights, teaching, and for his time. And Dr. Biswal sir
One
for
minute,
his
Sandeep, there's a question
Yeah.
on growth velocity. Dr. Sandeep,
Yeah.
before we conclude, there's a question on growth velocity. Somebody has put
Yeah.
a question.
Yeah. Dr. Atindra sir has
Basically,
put.
basically, you must remember the growth velocity is something which is very, very important. A child should be considered to be growing slower if between 2 and 4 years, 2 to 4 years, the height velocity is less than 5.5 centimeter per year. 4 to 6 years, less than 5 centimeter per year. And 6 years to puberty, if it is a girl, it is 4.5. If it is boy, it is 4. This is called rule of 5. Rule of 5. This is very nicely given in standard references. Thank you, Dr. Sandeep.
Yeah, thank you, sir. So once again, I'm thankful to Dr. Biswal sir for his expert guidance and enriching the discussion. Special thanks to Dr. Swadha for her excellent case presentation. We are extremely thankful to all the academy members, dear PG students for active participation, and also we thank Team Juventus for providing the digital platform for case presentation. So I think there are no more questions. So thank you all. And with this, we come to the end of this case presentation for today. And good night, all.
Thank you, sir.
Thank you.
thank you, sir. Thank you so much, sir. Good night, sir.
Thank
Good
you,
night.
everybody.
Thank you.
Night.